I just want to start with like the mitral apparatus, the structure itself. And this is important to understand the pathophysiology behind mitral valve disease. So it is an apparatus. It's just not the leaflets that's going to affect your mitral pathology. So it is like a fibrous skeleton, right? The apparatus is the fibrous skeleton. There are two leaflets, anterior and posterior leaflets. There are chordae, which come from both the papillary muscles. One is the posterolateral and the anteromedial papillary muscles, and both the papillary muscles will give chordae to both the leaflets. So especially the posterior leaflet is where we see a lot of ischemic MR, so that is supplied by RCA. That's another question on the boards, by the way. So it's an apparatus. You cannot just say it's the leaflet thing and end it there. So you have to look at the whole thing. And it's big. The annulus itself is like 4 to 5 centimeters big, unlike the aortic annulus, which is pretty small. This was the first valve that we could see well by echo. And again, first valve that we diagnosed by echo, first valve which was treated by commissurotomy, and M mode is classic. So just going back on a little history, on valvular pathology, mitral was the first. This, I think, all of you should come into memory as well. Transthoracic, when we look at the mitral valve on FOSS, A1 through A3, P1 through P3, A1 and P1 are next to the appendage. And this is how we see it, the middle image. This is how we first see it on transesophageal echo. And you have to turn this like 180 degrees to get this the smiling mitral valve. And this is the surgeon's view. Think about it. The surgeon never wants to enter the ventricle unless he has to. So he enters from the left atrium. So think about it like your patient's head, and the appendage is on the left, aorta is on the top, and next to the appendage will be A1, P1, and the nomenclature from there. And this is more important in mitral regurg, but we should know what it looks like. Okay. So what are the causes of mitral stenosis? The big one, mostly in developing countries, but again, as I said, we see it here. It's a rheumatic MS. And now in the developed countries more, it's degenerative mitral stenosis. As soon as you see this picture, you should know what it is. The anterior mitral leaflet becomes very thick, fibrosed. There's the commissures are fibrosed, thickened, and then fuse. And that's the whole pathology between mitral stenosis, rheumatic mitral stenosis. And 3D picture, you see this fish mouth. Calcification is towards the end of the disease process in rheumatic cases. It's initially more fibrosis and fusion. Unlike, and these patients are young, right? Recurrent streptococcal infections in younger folks. And this is the degenerative mitral stenosis that we see here. Patients are older, 70s, 80s. Most of them have diastolic dysfunction. They have aortic stenosis. They have hypertension. The MAC itself is like so severe, causes a lot of shadowing, and there's also blooming artifact around it. A lot of times associated with mitral regurgitation, and on short axis, the whole annulus, the posteriorly especially, it's all calcified, right? But again, this is a big problem to deal with. Patients are older too, so treatment is not that easy in these folks. So, okay, so causes-wise, rheumatic degenerative we discussed, but there are other causes as well. Radiation valvular disease, we have to think about, especially now, because all these patients who've had radiation a long time ago are coming up with radiation valvular and coronary disease. Carcinoid is important because this will mostly affect tricuspid valve, because from the liver lesions, it comes to the tricuspid valve causing tricuspid stenosis. But if there is a ASD or a PFO, or if there are lung mets, it does affect the left-sided valve, so we need to be aware. There are congenital causes of mitral stenosis when the leaflet formation itself is defective. Lutembacher syndrome has been asked on the boards, where there's an ASD and congenital mitral stenosis, that's Lutembacher syndrome. And parachute mitral valve has also been asked, which causes MS. Essentially, there is this one big papillary muscle which attaches directly to the mitral leaflets. There are no chordae, and causes restrictive movement of the leaflets. they'll give you this one picture and they'll want the diagnosis. Dr. Schulman is really fond of M mode, so even for his sake, you should know. But on the boards, they'll give you this one slide and they want the diagnosis. So your M mode will go through the leaflet tips. So E, F, the slope during is reduced, and the posterior leaflet, so the arrow marks here, right? The posterior leaflet is actually pulled is pulled because it's fibrous. The tips of the leaflets are fibrous, so they sort of go together, and again they're thickened. So you have to commit this to memory. First picture we start with is the parasternal long, and as soon as you see this, you should know and you should investigate further. So there is classic dooming of the anterior mitral leaflet and hockey stick deformity during diastole. Like the leaflets at the tips are fibrosed and they are thus separation is reduced. So this makes this classic hockey stick deformity. This picture, and you should know it. So this video, I think, helps a little bit more. It starts at the tip and progresses towards the base. I think there's a delay, guys. Give me 1 second. I do want to show you something on the... Okay. So it starts at the leaflet tips and then progresses towards the mid and the base. Unlike degenerative disease, which starts more at the annulus and then progresses towards the leaflet. So the way the disease process is different among the two conditions. Okay. And the classic fish mouth on the short axis. Because there's all this fibrosis going on, the excursion is reduced, and this is called the classic fish mouth. And this is important sometimes when you're doing mitral valve area. It is not ideal to do it from here, and that's what I want you to remember. So how do we assess the mitral stenosis and what's the gold standard? So we go back to this study. I think it was published in like 1984, I want to say. And this was done at Mayo Clinic, all rheumatic heart disease patients, 17 total. So we are not looking at like hundreds of patients. There were like 17 young patients with mitral stenosis. And they compared CATH versus echo. So CATH, they did like a septal puncture and recorded LA pressures and compared it with the pulmonary capillary wedge pressures. And at the same time, a continuous wave Doppler was performed. And this is a good example because, okay, here. So over here, you see this is the pulmonary capillary wedge pressure, right? This is the tracing of the wedge pressure, and this is the tracing of the LV. So there was a discrepancy. If you see by CATH, they were getting a gradient of 19, but by Doppler, they were getting a gradient of 12. There was a discrepancy. But when they did with CATH and Doppler with an LA catheter, they were comparable. And this was similar for all their cases. Again, this is wedge pressure versus LA pressure, right? So, and this is where echo really became important because this study proved that echo is very comparable to the gradients on CATH with LA. And we don't do LA, we usually go with pulmonary capillary wedge pressure, and it's not accurate. So if you want to be accurate, you have to do that. Versus now this continuous wave Doppler proves that echo is superior. So how do we actually grade it, right? So stenosis severity, the gradient is the most important thing. How do you do it? So it's a continuous wave Doppler. You have to go through the orifice of the mitral valve itself. And this is the contour you get. And so peak gradient is this. The peak is the E wave, right? And this is your peak gradient. And mean is the summation of the peak instantaneous gradient across all this time, right? So you take peak gradient here and across all this line, this is the mean gradient. And easily done because when we do TVI of the mitral valve, we get this, and mean gradient is calculated through this. Again, remember, it's a continuous wave Doppler. There is a vendor where there can be some artifact, and if you're in doubt if you're in the right place or not, if you want to confirm, so you can use PW, but it will not give you the peak velocity. And again, the window of the PW is small, so you have to accurately position at the leaflet tips. Only then it's more comparable. But again, gold standard is to use continuous wave Doppler. Peak is not useful. The E wave is not really useful because it depends on left atrium, it depends on left ventricle. If there's AFib, there's a problem. So mean gradient is always better. You always want to report mean gradient at a heart rate, because hemodynamics, right? If the heart rate is high, if the patient has anemia, once you improve your if there's more stroke volume, more cardiac output, it will increase your gradient. So always report it at a heart rate. If your heart rate is 100 versus 60, there's a lot of difference. At 100, 120, your gradients will be higher. So always report it at a heart rate. So you got a gradient of 10 or 12, but at a heart rate of what? So that would be very important.
Yeah, so yeah, the heart rates, the hemodynamics are very, very important with the mitral. I mean, all the valvular disease, but especially mitral stenosis.
Yeah.
And also, one thing I would like to reiterate is basically because it's not commonly seen, so it can be a little deceiving sometimes with the severity of mitral stenosis, especially if you're looking at the calcific one. Go by the gradients, and obviously you have to look at the heart rates. If there is any concern, you want to wait, like you want to reduce, you want to wait, like once the patient's heart rate is within optimal limits, you want to get better information again. But again, you're gonna at the end you're gonna put all the information together, right? Like the pulmonary pressures, left atrial size, and history, all that. But one thing I would like to say is, when people are so much used to looking at aortic stenosis and try to translate it to mitral, there'll be a problem, because with aortic, we get used to looking at the planimetry, the area also, right? Just looking at the valve, like is it opening well or not. So with mitral valve, it can be very deceiving, because a lot of times the stenosis can be subvalvular. So the valve looks like it's opening okay, but do not get deceived by it. It can be subvalvular. We saw at least a couple of cases recently like that. Yeah. Sorry, thank
you. No, good points, Geeta. So you have to be very careful with mitral because again, a little increase. So your velocity is right. It's 2.5. So your peak velocities are not going to go more than that. You will never see a peak velocity of 4 meters per second. So your being accurate is very important with mitral diseases. In atrial fibrillation, like all these patients tend to get atrial fibrillation. So if you have patients, it's very, very tricky. Like in HFpEF, right? The hemodynamics will change a lot. AFib, you have to use at least 5. Try to be like identical beats, RR intervals, because if your diastole is longer, there is longer filling time, so it is going to change. And ideally, as Dr. Bhumireddy said, you want to control their heart rate. All these patients have to go on beta blockers, and again, you have to put them on Coumadin if there's any atrial fibrillation. But hemodynamics wise, at least 5, because there'll be a lot of variation in your RR and your VTIs. There will be a lot of difference. So exercise hemodynamics is very important, especially if it's a gray zone. Young patients, maybe not symptomatic, but vague symptoms. So if you want to sort of investigate more, you should do exercise hemodynamics. And ideally, you don't want to do a treadmill, because that would be like post-exercise hemodynamics. You want to do it during their exercise and see what their PA pressures and mitral valve gradients do. So if your PA pressures are going over 50 and mitral gradients are really high, then you should consider intervention. This is level 2 recommendation, not level 1 though. But stationary, bike, exercise, echo is important to look at these things. Okay, so now you've got your gradient, and now you have to assess further what the valve area is. And level 1 recommendation is for mitral valve area by planimetry. And how you do it is important. As I said earlier, like if you're doing it on force, you don't know where you are. And especially 3D, there's a lot of blooming artifact around if there's any calcification. And again, this whole mitral apparatus, it's a funnel, right? The two leaflets will come down as a funnel. So you don't know which plane you're cutting it at, say on a 2D image. So ideally, you want to zoom in, you want to get a good 3D, both your annulus should be present, and then in a multiplanar reconstruction to get the mitral valve area. So you adjust all the 3 planes to get to the mitral valve leaflet tips and calculate your area there. So this is MPR, and again, this is the best way to get planimetry of the valve. Oh yeah, gain settings. So here, gain settings are very important, because if your gain setting is very high, everything will look more, right? So you will underestimate the valve area if the gain setting is is high. So you have to watch your gain settings as well. So instrumentation is important. Okay. Since I have John and Mansoor here, this is a question for the two of you, boards taking. So this is mitral, a continuous wave through mitral. Which one will you take? The one on the left where you will draw your slope like that, versus will you take this one where your slope is more with mid diastole? Which one? And if you want to go for Y, go ahead.
It's the right one.
Yeah. So you really want to see the mid diastolic slope. Initially, all this came by Dr. Hatley's research, and she published a lot of data as to why pressure half time and why you want to, and why it's useful. And that I have a slide on that, so I'll tell you more then. But again, later on, it was seen that when you have, say, a lot of MR, if the volume's too high, if there's diastolic dysfunction, you tend to get this peak. The peak velocity will be higher. And if you start there, your deceleration time will be very low. And this we see in HFpEF patients, right? When you do E over A, the decel time will be really low when it's advanced. You don't want to take that. For pressure half-time calculations, you want to take the mid diastole. If you get a question on this, thank me later again, because this is very classic, very, very testable on the boards. Okay, I have another question. This is from Alan Klein as well, written by Dr. Paslaro. Mansoor, can I have you go through it?
Yeah, sure. So the question says, during routine assessment of a patient with non-valvular disease, the sonographer measures a mitral inflow deceleration time of 758 milliseconds. Which of the following is a reasonable estimate of the mitral valve area? So correct me if I'm wrong, but to get the pressure half time, I think it's 2/3 of the deceleration time. So I'm trying to calculate here with my phone.
So it's 0.29 times deceleration time. And
yeah, the third, yes.
Yeah.
Times deceleration time was 758, which gives me 219.
Yeah.
Which is, so it's going to be around 1.
Yeah. So 220, again, two formulae that you really have to commit is that, again, as you said, 1/3 of decel time, 0.29 times decel time is pressure half time, and 220 over pressure half time gives you your valve area. So excellent. You're ready, man. But it all goes back to this slide and this one. So this slide, right? You really have to understand the hemodynamics around this slide. Very, very important, because I had a question on my board as well. So what is a deceleration time and what is pressure half time, right? This is for I think the first year and the second year fellows. Pressure half time is the amount of time, or rather amount of time it takes for the peak pressure, peak instantaneous pressure to decay into half of what it is. So as I said, like peak pressure over here will be 4V square. So it's about 2. So you get a peak pressure of like 16. So how much time is this going to take to decay into half? And that is pressure half time. So typically we measure deceleration time from the peak and bring it all the way to the baseline, and that would be the deceleration time. And when you want to calculate by the velocity itself, the formula would be 0.7 times Vmax. And that's where your pressure half time is. So the time from this peak to 0.7 times the Vmax, this distance would be pressure half time. And the valve area, as I said, the math is very important. If as your deceleration time and pressure half time are increasing, your valve area is decreasing. So you have to be cognizant. But remember, all this data comes from this publication, 1987, long time ago. Dr. Hatley, she studied 73, 74 patients, young patients, severe, moderate to severe mitral stenosis, and this was related CATH and echo both. So you're looking at young patients and checking their pressure half time, and over 220. When she correlated this with CATH and valve area, pressure half time of over 220 was the most accurate. And that's where we get all this data from. But remember, these are younger folks. You cannot do this in older degenerative mitral stenosis. That would be wrong. So always remember that if it's degenerative pressure half time, you have to be very careful. So excellent in younger folks, but it depends on your left atrial compliance. It depends on your LV diastolic dysfunction, and acutely, if there are hemodynamic changes, it will depend on that. Say you do a mitral valvotomy, within 3 to 5 days, you cannot use pressure half time to calculate the mitral valve area because the left atrial compliance changes acutely in such a situation. Severe AI, severe MR, your E wave is going to change because your LVEDP is different. It's changing. So you cannot use pressure half time in these patients. And atrial fibrillation, again, all your VTIs are different, pressure half times are different, extremely challenging to measure. So you cannot use it there. So, but again, if you have a question where you are asked to pick the best method of mitral valve area, do not use it in patients with degenerative mitral stenosis.
A quick question.
Yeah.
Yeah, because a lot of this, we get these patients with calcific mitral stenosis that also have diastolic dysfunction. Is it that we cannot use it at all, or is it for severe diastolic dysfunction?
It's for severe diastolic dysfunction. And again, these patients are not easy, and I would recommend using other ways of doing it. You can use, there are 3 more ways how you can get mitral valve area, and you should use other ways, including continuity, which will be on this formula. Manish is asking a question, guys. 1 second. Yes. Like severe AI, severe MR, AFib, you cannot use pressure half time. So these are again patients who've not undergone mitral valvotomy, younger folks without any other problems. These are the patients that were studied, and that's where the data is coming from. So we should not extrapolate it to current generation degenerative MS. If anybody started on the math on this question, this is on continuity, and I'll explain why this is important for MS.
I can do this one, Supriya.
Yeah.
So I calculate the stroke volume through the LVOT. It's pi r square times the VTI. So it's pi times 1 centimeter times square times 25. So it's 50 cc's. And then for the so that's a stroke volume through the LVOT, and then through a stroke volume through the mitral valve, I'll do the same thing, pi r square times the VTI, using those measurements, 4 centimeters. So 2 centimeters would be the radius. And then 10 would be the VTI. And then I subtract the stroke volume through the mitral valve minus the stroke volume through the LVOT.
Yes.
So I think I got 125 minus 50, so around probably 78 would be the answer.
Let
me see.
78 or
I'll double check again.
Yeah, it's the math that you need to check, but the concept is absolutely right? It goes down to, it goes back to continuity equation, and you can use this for mitral stenosis as well. It's not just mitral regurgitation. I'll wait for your math a quick second. If not, we'll start discussing the continuity equation and why in MS. And the question is from Alan Klein, if you want to double check later.
Okay, sounds good. Yeah, I basically got pi r squared times VTI, so pi times 2 squared times 10, so it's 25. And and then for the stroke volume through the LVOT, it's pi times 1 squared times 25. I think maybe that was wrong there. I think let me see. Oh yeah, so it's 125 minus 78. So 47.
47 then.
Yep.
Okay. Yeah, so the answer is B. So here, continuity equation, right? If you're calculating this, we always do for our aortic stenosis patients, right? Whether you do a so stroke volume through the LVOT or like aortic stenosis, diameter versus the VTI at that spot, right? Same thing we can do with mitral. You could potentially do it with pulmonic valve as well, but it's very hard to measure pulmonic valve diameter and stuff. So we do it more with, for mitral, we do it more with aortic. So when you want to calculate the mitral valve area, if you have a gradient across, a TVI across, you can, as you said, like calculate the stroke volume and then subtract this from that. And this has a level 2 recommendation. So pressure half time and direct planimetry level 1 recommendation, and continuity equation and PISA these two are level 2 recommendations. So PISA can be done. There was actually a question on board preps. What does PISA stand for? And they'll give you several options, so don't get confused. It's proximal isovelocity surface area. And the math around this, they will ask you. So you have to be good with this. So what is the concept, right? So we go back to this really old slide. I think I got it from an NEJM article, where LA, LV, and as your blood is accelerating from the left atrium into the left ventricle, going through the small orifice, it is going to accelerate to get through this. All the potential energy is going to change into kinetic energy to get through this orifice. So when you change your Nyquist limit, so you have to change your Nyquist limit, whether it be MS, MR, or AI, you have to change your Nyquist limit, and you have to change it towards the direction of the flow. So in mitral stenosis, the direction of the flow is towards the LV. So you change your Nyquist limit towards the LV, drop it to 30, 40, and it forms shells. RBCs traveling at different velocities will form shells. And these shells, you get the diameter out of that, right? And with the math, there is an angle correction, alpha over 180. Because when we are doing it for mitral regurgitation, so you shift your Nyquist limits towards the left atrium because the regurgitant jet is towards the LA. And you get your radius from there. But here, as the mitral valve leaflets close at an angle, you have to do an angle correction. And this is the difference. It can be done. I think it's very tedious. I don't think we do enough with MR, but if we have a case and there's no other way, level 2 recommendation to do a PISA method of calculation. And this would be a maximal velocity for math. And the formula we all know, but I put it there for you guys. All of them have their own problems, and you have to put all the data together before you come up with the severity of the disease, right? Like pressure half time, if you have a young patient, then it's excellent, and it's so easy to do, but there are limitations to this, as we discussed already. Planimetry, you look at the valve directly, and if you can do a good multiplanar reconstruction, that is ideal. But again, watch your gain, watch the blooming around the calcium. So and it has to be multiplanar. If you do it directly from like an on-pause 3D of the mitral valve, that's not going to work. You will overestimate the severity because of all the shadowing around it. The valve will look smaller than it truly is. And again, you might not get the right plane, so you will be underestimating it. So always multiplanar reconstruction is the answer to that. Continuity equation can be done. But again, limitations include AFib and regurgitant jets. And where do you become like mild, moderate, and severe with these, right? And now there's very severe as well. I have it on the next slide. So as the gradients start increasing, 5 to 10 in the moderate range, more than 10 is in the severe range, and PA pressures are important. If there is exercise-induced PA pressure elevation to 50 or more, then it's a class 2A recommendation to do a mitral valvotomy for rheumatic patients. Okay, so this is a question. Oh, sorry. Before I discuss the Wilkins-Abascal score, now what kind of patients are good for balloon valvuloplasty, and what are the indications? So this question is based on that. If anybody wants to take a dig.
I can do this one, Supriya.
Yeah.
I think the answer is basically the first one, asymptomatic 29-year-old with a mitral mean gradient of 9 and resting TR velocity of 4. So the PA systolic pressure would be 64.
Yeah.
And then like the second one, at least from the 220 divided by 110 is 2 centimeters square, so it's not severe.
Perfect.
The third one is like a degenerative MS, and the fourth one likely has severe MR or at least moderate to severe MR, which is a contraindication.
Perfect. You went over everything. I don't need to discuss the next slide, John. But yeah, here, although, so it's a class 2A indication. The only thing here tricky is that this patient is asymptomatic. So class 2A indication for patients who have elevation of PA pressures who are asymptomatic. And if they have a favorable anatomy, they should get a mitral valvotomy. Others, as you said, there's MR, no, and if there is a left atrial appendage thrombus, then you cannot do a mitral valvotomy. So that goes back to the Wilkins score. They might quiz you on this. So this is a Wilkins-Abascal score, and this grades mobility of the leaflets, thickening of the leaflet, calcification, and if there's any subvalvular thickening going on. Score goes from 1 to 4, depending on the severity. And if the Wilkins-Abascal score is less than 8, it's favorable to do mitral valvotomy in patients' benefit. But if it's more than 8, then not so favorable. And the big thing is calcification, basically. I mean, you go through all this, but later on they looked at just calcification, and that was the most important thing driving prognosis in patients, how they did after a mitral valvotomy. And this is, I got it from the guidelines, just a pictorial representation of the thickening and the calcification and mobility, whether it starts at the leaflet tips and then how it progresses. This is more sort of pictorial representation of the Wilkins-Abascal score. Again, remember 8 is a magic number. Less than 8, it is favorable to do mitral valvuloplasty. And I quiz you on like what are the components of it, right? The like mobility, thickening, calcification, and the subvalvular thickening. Everybody gets that wrong sometimes. So I don't think they'll quiz you on all the details of the scoring or the grading system, but you should know the 4 categories. Okay, so this is from the 2014 valve guidelines, and we are for all the valves we are going towards at-risk, progressive, and then severe, whether symptomatic or asymptomatic. And I think it's good to go through the slide, especially when it becomes severe. And so if there is a mitral valve area, you're getting it less than 1.5, or very severe, you're getting it less than 1. If the pressure half time is over 150, it would be severe. Over 220, it would be very severe. And if, again, elevated PA pressures. Symptoms or no symptoms. If they don't have symptoms, then you can perform like a bike stress echo. And if the anatomy is favorable, then it's a class 2A indication to intervene. But if they're symptomatic, then it's class 1 indication to intervene. again, you have to. So once you know whether it's progressive, whether it's severe or very severe, what do you do next, right? And that's where the role of TEE is. You want to check for MR, as John said. If there is more than moderate MR, it's a relative contraindication for balloon mitral valvotomy, because basically you are splitting it open. You're splitting the orifice open, and if it's already moderate or to severe MR, you're just going to make it worse. That one, and AFib, and left atrial appendage clot. If there is left atrial appendage clot, it's a contraindication. It just causes stroke. You don't want to get in there. And for whatever reason, if balloon mitral valvotomy is not feasible, then you go ahead with an MVR. If it's because of clot, if it causes more MR, then you go ahead with mitral valve replacement. Okay. This is a busy slide. I think you guys can take a look at this from the guidelines. This is directly from there. Again, what are the class 1 indications and class 2A indications? You can go through this. Okay,